hôm nay và chủ tọa với tôi hôm nay thì có thầy phó giáo sư tiến sĩ Lê Văn Phước và tôi bác sĩ Lê Văn Khảng tại Trung tâm Điện quang Bệnh viện Bạch Mai. Thì xin mời thầy ạ.
Như vậy cái bài đầu tiên của phiên đầu mạch cổ thần kinh của phó sư là Rohini Nasri thì cô có bận việc và cũng không trực tiếp online được, và có gửi cái video cho chúng ta xem. cái bài này là hình ảnh của xâm nhiễm của u quanh dây thần kinh. Xin mời. Professor Nasri thì đang làm việc ở tại trường đại học Johns Hopkins, cũng khá nổi tiếng ở Mỹ, về cùng khoa hình học và khóa học về cái X-quang. Xin mời.
I am grateful to the VSRNM for the opportunity to speak to you today on perineural tumor spread.
These are my disclosures, none of which are relevant to this talk.
I will be discussing the definition of perineural tumor spread, its diagnostic importance, as well as imaging features.
There is some confusion between two differing terms, perineural tumor invasion and perineural tumor spread, because they're often used interchangeably in the literature. To be clear, perineural invasion is in fact a histologic diagnosis that's made within the primary tumor specimen at the time of original diagnosis. So this is very localized disease at the site of the primary tumor. Whereas perineural tumor spread is a pattern of malignant tumor metastatic disease. So the tumor has extended beyond the confines of its primary site into the skull base foramina and along the course of several nerves that are in the anatomic region. And this is far less frequently seen than perineural invasion, which is the histologic diagnosis. Again, to clarify, perineural tumor spread is a macroscopic diagnosis that we can make on imaging. Perineural invasion is a histologic diagnosis made under the microscope. So when do we suspect perineural tumor spread on imaging? Well, when we are evaluating patients with primary cancers, the main players are going to be squamous cell carcinoma, either mucosal-based or cutaneous-based, like a skin-based cancer, and adenoid cystic carcinoma, which is a primary tumor of the salivary glands. These are the two most common tumor types that have a propensity for perineural tumor spread. And so when we're reading these kinds of cases, we're going to have to pay extra careful attention to the skull base foramina and nerves for metastatic disease. There are other players as well, basal cell carcinoma, melanoma, mucoepidermoid carcinoma, and lymphoma, which also have propensity for perineural tumor spread. What is the importance of making this finding? Well, presence of perineural tumor spread can increase the risk of a local recurrence, and of course will alter the staging of the patient's tumor with a worsened prognosis. The presence of perineural tumor spread will also affect the treatment planning, because it's very difficult to excise a tumor that has perineural tumor spread. This will require potentially expansion of the surgical resection margins in the hopes of getting the entire tumor resected, and it will increase the radiation field that the patient will require to keep the disease under control. Patients are typically going to present with symptoms related to the specific nerve involved with perineural tumor spread. That said, those symptoms might be very subtle or might not be readily appreciated by the patient or the clinical service at the time of primary diagnosis, because other features might overwhelm the clinical picture, such as very large bulky adenopathy, for example. Perineural tumor spread can occur at any time, and it can occur in the setting of recurrence of a previously treated tumor. And once in a while, we'll see patients who present with symptoms of perineural tumor extension, and that can be confirmed on imaging without a clear primary tumor evident. Perineural tumor spread is a very challenging diagnosis to make. These abnormalities don't just pop off the images. One has to know to hunt for them and look for them. And in that sense, the clinical context is very important to make the accurate diagnosis. So knowing that a patient has a particular primary malignancy, that it's prone to perineural tumor spread, as well as a clinical picture that looks suspicious for perineural tumor spread will raise our diagnostic certainty and accuracy. On imaging, we're going to look for findings of perineural tumor spread that extend contiguously from the primary site of tumor. We're going to look for enlargement of the nerves, nodular or thickened enhancement along the nerves. We're going to look for enlargement or erosion of the foramina through which these nerves course. We're going to look for obliterated fat planes, which typically reside within the neural foramina. And we're going to look for extra soft tissue masses, nodularity at the foramina where these nerves live. Knowing the complex anatomy of nerves in the skull base will help in identifying perineural tumor spread. The trigeminal nerve, otherwise known as the fifth nerve, and the facial nerve, otherwise known as the seventh nerve, are going to be the most commonly affected by perineural tumor spread, and they're going to be the focus of today's talk. These nerves are going to supply most of the sensory and motor innervation to and from the face. And to make things more complicated, they have branches that can connect with one another. The trigeminal nerve itself has three major branches. We have the V1 or ophthalmic branch, V2 or maxillary branch, and V3 mandibular branch. The V1 or ophthalmic nerve courses the cavernous sinus and enters the orbit via the superior orbital fissure seen here on this schematic. It has three major branches, the nasociliary, the frontal, and the lacrimal branches, which supply the skin, which are common sites of cancer, as well as the lacrimal gland, which is another site of primary tumor. So in those clinical settings, we would look for potential spread along the branches of V1, back through the superior orbital fissure and into the cavernous sinus. The V2 or maxillary nerve is going to course from the cavernous sinus and through an orifice here called the foramen rotundum. And from there are going to be a number of neural connections at this region here called the pterygopalatine fossa, situated just behind the maxillary sinus. As you can see, there are very numerous branches of the V2 nerve that subserve various functions. One of the major players is going to be this infraorbital nerve, which travels in the infraorbital foramen before coming out into the soft tissues of the cheek. So with the number of nerves involved, there is a great propensity for tumor spread from the orbit, face, palate, and nasopharynx. Again, squamous cell carcinoma and salivary tumors are going to be the biggest players in this regard. The V3 or mandibular division branch of the trigeminal nerve courses through the foramen ovale and has two major divisions. The anterior division, which is mostly motor and innervates the muscles of mastication predominantly, and there is a posterior division branch that is mostly sensory, that supplies innervation from the chin, lower lip, tongue, and lower face. You can imagine that a skin cancer at the chin, for example, can extend in a retrograde fashion along the mental nerve and make its way all the way back along V3 to the central skull base. The facial nerve, or the seventh nerve, provides motor innervation to the muscles of facial expression primarily, as well as sensory innervation to the periauricular soft tissues, as well as taste to the anterior two-thirds of the tongue. The facial nerve does take a complicated course within the skull base, but ultimately it exits the skull through the stylomastoid foramen and courses through the parotid gland. Given its intimate relationship with the parotid gland, it is a conduit for tumor spread from primary parotid neoplasms back towards the skull base. To make matters even more complicated, the facial and trigeminal nerves have distal branch connections. The biggest player in this regard is the auriculotemporal nerve, which is a branch of V3 that does have communicating rami with the facial nerve within the parotid gland. The greater superficial petrosal nerve depicted here shows the connections between V2 branches at the pterygopalatine fossa with the geniculate ganglion of the facial nerve. And then finally, the chorda tympani does create a communication between V3 and facial nerve branches as well. In this way, perineural tumor spread can go from one nerve to another. So let's translate what we've just seen into anatomic imaging. Here are some coronal CT reconstructions which show the orbital apex region, which consists of coalescence of the superior orbital fissure containing those V1 branches, the inferior orbital fissure containing some branches of V2, as well as the optic canal, which carries the second cranial nerve or the optic nerve. Slightly more posteriorly, we have the foramen rotundum, which sits just along the lateral margins of the sphenoid sinuses containing V2 branches. We have the Vidian canal coursing along the undersurface of the sphenoid sinus. And even more posteriorly, we see this large defect at the skull base on both sides. This is the foramen ovale, which transmits our cranial nerve V3. We can see these anatomic structures even in greater detail by MRI. On these T1 non-fat suppressed images, we can see the neural structures at the orbital apex, including those coalescing from the superior orbital fissure, the inferior orbital fissure, and the optic canal. Notice the stark contrast between the soft tissue signal of the nerves and the normal fat around these nerves. So slightly more posteriorly, we're going to see again the V2 segment within foramen rotundum and a smaller Vidian nerve in the Vidian canal along the undersurface of the sphenoid sinus. And posteriorly more still, we can see the very thick, hefty V3 nerve root as it courses through the foramen ovale on both sides here. Notice the nice clean fat within the trigeminal fat pad as this nerve extends through the skull base into the masticator space below. As I mentioned previously, the pterygopalatine fossa is a complex anatomic region which is essentially a sort of hub for neural connections of V2 branches. The pterygopalatine fossa can easily be seen sitting just behind the maxillary sinus on both sides. There are neural connections through the sphenopalatine foramen to the nasal cavity. There's also connections to the masticator space, the pterygomaxillary fissure. More posteriorly, the Vidian canal and the foramen rotundum allow for communication with the intracranial compartment. And then we have the inferior orbital fissure, which gives us access to the orbit, as well as the greater and lesser palatine foramina, which give us access to the hard palate structures. In this manner, sneaky perineural tumor extension can course along the pterygopalatine fossa and gain access to the face, orbit, central skull base, and intracranial compartment. When perineural tumor spread is suspected, an MRI of the skull base is going to give us our best chance at making that diagnosis on imaging. The high-res skull base protocol is going to include heavily T2-weighted 3D sequences using gradient echo or FSE techniques. These are very fluid-sensitive images and are isovolumetric, so they allow for very high-resolution multiplanar reconstructions. 3T magnet provides greater signal-to-noise than 1.5T, so 3T is preferred, but 1.5T can do just as well. The advantage of these images is that it gives high contrast between fluid and the adjacent soft tissues, which is perfect for identifying cranial nerves, especially pre- and post-contrast comparisons. Similarly, isovolumetric gradient echo T1 sequences pre- and post-contrast can give us excellent insight into the presence or absence of perineural tumor extension. So let's put this knowledge into practice. This is a patient with a right temple scalp squamous cell carcinoma, a skin cancer that was resected, and is now presenting with periorbital paresthesias. So immediately we have to suspect perineural tumor extension. If we scrutinize the lateral orbit, we can see that there's asymmetric enhancement along that lacrimal branch of the V1 segment on the right side compared to the normal appearance on the left side. Knowing that we need to trace this nerve back to the central skull base, we see that there is bulky asymmetric soft tissue within the superior orbital fissure and extending into the cavernous sinus. Now I know that the cavernous sinus conveys more than just the V1 nerve, but there are also other cranial nerves that I need to give attention to. And lo and behold, we do see that there is in fact abnormal enhancement along the V2 segment as well, extending from foramen rotundum through the inferior orbital fissure, as well as posteriorly back towards the Meckel's cave region. So this is an example of how perineural spread can be very sneaky, and you can miss it unless you know to look for it. This is a patient with skin cancer of the face presenting with some left-sided paresthesias. On these CT images, we can see asymmetric soft tissue on the left in front of the maxillary sinus. I know that my V2 infraorbital nerve is exiting right at this location, and so I'm going to suspect that there's a high probability of extension along that nerve back towards the pterygopalatine fossa. And no surprise, there is asymmetric soft tissue within the left pterygopalatine fossa compared to the right. Notice how we have normal low-density fat tissue on the CT image on the right side, which is completely obliterated on the left side, indicating perineural tumor spread. On our coronal reconstruction, we see complete loss of soft tissue structure planes. On the right side, we have the normal fat intervening within these soft tissues, but it's completely obliterated on the left side due to perineural tumor extension. Similarly, we see asymmetric soft tissue within the inferior orbital fissure on the left side, indicating spread along the pterygopalatine fossa. On bone windows, we can see that the affected region shows sclerotic appearance of the bone, and the skull base foramina, rotundum and vidian, respectively, are larger on the left side compared to the right side, all indications of perineural tumor spread. This is a patient with melanoma, and this is a really subtle example of perineural tumor extension in a similar distribution. This is my infraorbital nerve, my V2 branch on the left side, which is much larger on this side compared to its normal counterpart on the right side. Tracing that nerve back, I can see it's enlarged as it courses the infraorbital foramen and heads back towards the pterygopalatine fossa. Then the foramen rotundum is similarly enlarged, indicating perineural tumor spread. On post-contrast images, we can see the abnormal enhancement along that foramen rotundum V2 segment. On the coronal, you can see this very pronounced asymmetric enhancement of foramen rotundum as well, indicating spread along the V2 segment. This is a patient with perineural extension along V3. The patient has a history of nasopharyngeal carcinoma, which also has a strong proclivity for perineural tumor extension. We can see on the coronal T1 pre-contrast image a normal V3 nerve root with the nice clean fat surrounding the nerve within the trigeminal fat pad. However, on the left side, all that tissue is sort of replaced by this infiltrative tissue signal. On post-contrast images, we can see that there's asymmetric thickened nodular enhancement along the V3 segment of the trigeminal nerve, as well as discrete focal nodular mass along the course of the nerve as it enters the intracranial compartment. So this is another example of perineural tumor spread on V3. How about cranial nerve 7, our facial nerve? In this example, we have the stylomastoid foramen, where the nerve extends from its intracranial course into the parotid gland. Here it is abnormal appearing on the left side, where there is this infiltrative dark tissue investing the nerve. Compare that to the normal side here, where the nice clean fat of the stylomastoid foramen is preserved, and you can see that dot in the center indicating the normal facial nerve. We can also appreciate that on post-contrast imaging, the facial nerve is thickened and abnormally enhancing on the left side compared to the right. Let's look at those cranial nerve 7 and cranial nerve 5 connections. Here we have the normal appearance of the stylomastoid foramen on the right side once again, and we see the facial nerve beautifully depicted as that little low signal intensity dot in the center of it. On the left side, however, in this patient with a known parotid malignancy, we have lost that normal fat signal within the stylomastoid foramen, indicating perineural tumor extension. If we follow that facial nerve intracranially, you can see that it is thickened and abnormally enhancing along its entire cranial nerve course. However, we can also see extension along the greater superficial petrosal nerve into the central skull base region at its connection with V2, indicating now that the perineural spread has not just involved the 7th cranial nerve, but now has jumped to involve the 5th nerve as well. This is a patient who presented after resection of a left cheek squamous cell carcinoma. The patient is presenting now with a facial nerve palsy. Notice that there is abnormal thickened T1 hypointense signal coursing through the region of the parotid gland where we expect the facial nerve to reside, but also extending into the masticator space. Although we don't see the auriculotemporal nerve proper, this is the expected course of that nerve extending behind the mandibular condyle. And so we have very strong suspicion for extension, not only along the facial nerve, but also extending towards the fifth nerve. And we can again see that there is abnormal enhancement surrounding the trigeminal V3 segment, and on a coronal post-contrast image, again, we see this abnormal widened foramen ovale with tumor extending along V3 to the central skull base. In summary, perineural tumor spread is a very tough diagnosis to make and does require knowledge of anatomy as well as the clinical context. MRI is going to give us our best chance at making the diagnosis, particularly our high-res MRI skull-base protocol will really help us in making the clinically suspected diagnosis of perineural tumor spread. Thank you.
Vâng, cảm ơn giáo sư Rohini Nasi rất là nhiều, một cái bài giảng.
I'm grateful to the DSRNM for the opportunity to speak to you today on
một cái bài giảng rất là hay, từ giải phẫu cho đến cơ chế đường lan của cái tổn thương lan quanh thần kinh. Và tôi nghĩ bài giảng này thì nó rất xứng đáng cho chúng ta đã bỏ công sức có buổi thứ 7 để có mặt ở đây để nghe được những cái bài giảng chất lượng như thế này. Và xin cảm ơn. Và tiếp theo